For this series, we like to highlight the work of our fellows and junior faculty whose work and mission is of interest to the rounds and also that of the speaker. Today, we're delighted to have with us Dr. Sabrina Klusman. Dr. Klusman is a licensed social worker and research fellow at our HIV center here. Dr. Klusman earned a PhD from NYU, and her research agenda focuses on advancing health equity by examining how intersectional stigma disrupts engagement in mental health, substance use, and HIV prevention and care. They develop, implement, and evaluate multi-level interventions using community-engaged methods to ensure these implement strategies are culturally responsive and scalable for transgender and gender-expansive community. I'd like to now invite to the stage Dr. Klusman, who will introduce today's topic and our speaker.
Hello, everyone. Thank you so much. Today's Grand Rounds is in celebration of Pride Month, and we are delighted to have as our speaker today Dr. Richard Bränström, a psychologist and associate professor of public health in Karolinska Institutet in Stockholm, Sweden. Dr. Bränström's work focuses on the health consequences of structural forms of stigma and on identifying biopsychosocial mechanisms that may help to understand stigmatized populations' increased risk of poor health. He is leading several research projects aimed at better understanding the health and living conditions of lesbian, gay, bisexual, and transgender people. Dr. Bränström has received several grants from the Swedish Research Council and is the author of numerous publications in top-ranking psychiatry and public health journals. Please join me in welcoming Dr. Bränström.
Thank you so much for that introduction. My name is Richard Bränström, and I work as a researcher at Karolinska Institutet, where I lead a research group focusing mainly on the mental health of sexual and gender minority people, that is, individual identifying as gay, lesbian, bisexual, and those identifying as transgender, trying to understand the structural and biopsychosocial mechanisms underlying sexual and gender minorities increases for poor mental in particular. And today I was planning to present some of the results from the studies we've been working with during the past couple of years. So just to begin, I have no conflict of interest to disclose. I was also asked to outline a few specific learning objectives, and those are written here. After attending the session, you are expected to be aware that sexual and gender minorities has an increased risk for mental health, and that difference can be identified early in life. And I will illustrate that with some data from a Swedish context, and understanding why sexual and gender minority mental health depends on where they live, and presenting results from across Europe. Also know more about how social stress exposure can lead to increased risk for poor mental health through specific biopsychosocial mechanism, and I will give a few examples of that type of mechanisms that we've been trying to study. Those studies will be based on longitudinal studies we have ongoing here in Sweden. I included countries in which these studies are conducted, and I did that for a reason. As you will see from some of the studies, the situation for sexual and gender minorities really differ depending on in what environment they live. So therefore, the country context is of vital importance. And also the large majority of studies to date have been conducted in North America, and in particular in the US. Lately, we've been seeing a little bit more of studies coming from other countries and more studies from a European perspective too. But all data that I present today come from Europe. So why should we look specifically at the health of sexual and gender minority people? Well, many studies have shown that sexual and gender minority individuals represent a high-risk population for poor mental health, and that this has been shown in many countries across the world, and we can see it in a Swedish context too. Here are some results from a study in Sweden reporting on data from the Swedish National Public Health Survey, which is a survey regularly conducted in random samples of the population 16 years and older. And it has included questions about sexual orientation and transgender experiences during the past 15 years or so, making it possible to compare health status in different groups. When these questions are asked, and this is similar to what is often seen when questions like this is asked in population samples. So the sexual orientation groups are based on a question about sexual orientation, and then there's a separate question about transgender experience. But around 92-93% report as heterosexual identity, just over 1% report a gay or lesbian identity, and almost 3% report a bisexual identity. And on the question of trans experience, around 0.7% has been every year approximately report having that experience. So these are small minority groups in the population, and it's similar numbers. Of course, if you look at the younger age groups, you see slightly higher proportions. In this survey, there's questions about depressive symptoms, for example, making it possible to categorize people into those having elevated depression symptoms. Here we see that 16% of those identifying heterosexual can be categorized as having elevated depression symptoms, around twice as many among those identifying as gay and lesbian, and even higher among those identifying as bisexual, and a similar elevated risk among those reporting a trans experience. There's other questions in the survey of suicide thoughts, suicide attempts during the past 12 months, and we see a similar pattern, 2 to 3 times or 2 and 2.5 times increased risk of these mental health problems. And this is similar to what has been seen in other studies. In this particular study, we will also be able to link the survey responses to data coming from national registries on healthcare treatment. So we were curious to see how much treatment are these people receiving in psychiatry. So we looked at common psychiatric treatments, so depression, anxiety, and substance use disorder treatment during the year of they answered the survey. The survey happens early in the year, and this is the follow-up during the year. And we saw this pattern. So a little lower proportions receiving treatment, but a similar pattern that around 11% were receiving some kind of depression treatment, either psychiatric visits or antidepressant treatment, and around almost twice or 2.5 times as likely among those identifying as gay, lesbian, or bisexual, and also twice as common among those reporting a trans experience. So not only are sexual minorities reporting more symptoms, they're also experiencing or receiving more treatment for common mental health problems. The fact that we could link survey responses to national register data also enable us to these registries now also date back almost 20 years back in time. So at least for the young proportion of the survey respondents, we could also see how did their treatment history look like going back in time. So we were curious to see at what age could we see disparities. So we looked specifically at depression and anxiety, or what we call internalizing mental health diagnoses that are fairly common that you get diagnosed with during childhood and adolescence. So here we have age in years on the x-axis and the proportion ever being diagnosed basically with an internalizing mental health diagnosis divided by the different sexual orientation groups. And here I also split it up female and male. So these are people who identify as heterosexual, gay, and bisexual as adults, and their history of treatment for psychiatric diagnosis during childhood and adolescence. And as you can see, for the male group, bisexuals, men were around twice as common to having been treated for an internalizing mental health diagnosis during childhood and adolescence. And this difference was significantly elevated around age 15, 16. For women or girls, you could see a even greater difference that on average, or heterosexual, those identifying as heterosexual as adults had a history. About 8% had received an internalizing mental health diagnosis during childhood and adolescence, and 15 among those identifying as lesbian, and among those identifying as bisexual. As adults, around 25% had a history of being diagnosed with internalizing mental health diagnosis. So you can see quite large disparities here, and they happen quite early in the development period. Around age 13, 14, it starts being significant. So this, of course, has implications for who you meet as a psychiatrist in child and adolescent psychiatry. We also looked at neurodevelopmental diagnosis and saw a similar pattern, but much lower proportions. Slightly elevated likelihood of bisexual men being diagnosed with a neurodevelopmental diagnosis, but especially bisexual women had an elevated likelihood, and also lesbian women a little bit higher likelihood of being diagnosed with these diagnoses. When we looked at those reporting a transgender experience in adulthood, we saw a similar pattern, and here we saw quite elevated likelihood of being diagnosed with an internalizing mental health diagnosis, but also a neurodevelopmental diagnosis. Here, these differences could be noted already at age 14 for internalizing mental health diagnosis, and already at age 10 for neurodevelopmental diagnosis. So clearly these differences are substantial and happen early in life. So that, of course, has consequences how we think about the reasons why people are experiencing, or sexual and gender minorities have this increased risk. So why do sexual and gender minority individuals have an increased risk for poor mental health? In our research, we based our studies on leading theories about stigma and social stress, like the minority stress theory and its extensions. And these studies describe these theories describe the source of sexual and gender minorities' increased risk of poor mental health as exposure to stigma at different levels. Stigma-based social stress towards sexual and gender minorities is fueled by stigma at a structural level, and namely discrimination within a country's legislation and population attitudes towards homosexuality, for example, or transgender identity. For example, legislation with implication for sexual minorities can be things like lack of legal protection for same-sex married couples, lack of adoption right, lack of protection against hate crimes, lack of protection against discrimination in the workplace and in education, and at a structural level also population attitudes contribute to stigma. And similar for transgender people, things like lack of possibility to change legal gender, stigmatizing requirements to change legal gender, and also population attitudes. And these are things that really vary quite extensively in different countries across Europe. And it's also worth mentioning that even though these are geographically quite located quite close together, there are quite distinct cultural settings with different languages, educational system, and career possibilities. So it is quite different, even though they are geographically quite together. And as you can see on this map, there's also a lot of differences when it comes to rights for sexual and gender minorities. Structural stigma can also serve as to justify stigma at other levels, namely at the institutional level. Institutional stigma, and at the institutional level, unfair treatment in education, education, workplace, and healthcare setting, and a religious setting can, of course, also influence mental health. And at an interpersonal level, stigma manifests as things like victimization, harassment, social exclusion, and day-to-day reminders of social difference, often starting in childhood with school bullying, for example, and persisting throughout the lifespan with exclusion or different situation in family settings, for example. So stigma at all three of these levels are believed to contribute to sexual and gender minorities' increased risk. And I will present some studies where we have conducted using some data from Europe, showing a clear association between these exposures at different levels and adverse health among sexual and gender minorities. But in addition to studies of stigma and social stress, we also try to identify some biopsychosocial mechanism through which these types of exposures operate. And according to Minorities theory and its extensions, a number of mechanisms are linking exposure to social stress to poor mental health. As examples of cognitive mechanisms, hypervigilance describes the psychological process through which some individuals learn to anxiously anticipate rejection because of their membership of a stigmatized minority group. As example of emotional mechanisms are loneliness and shame. Behavioral mechanisms can be things like social avoidance, lack of community engagement, and that also contribute to the disproportionate adverse mental health among sexual and gender minorities. We have also started investigating the contribution of some specific biological mechanisms, more specifically stress-induced low-grade chronic inflammation. And I will present some of our results regarding that in a moment. And so this is an illustration of a conceptual model that we try to use in our studies, how we kind of think about the risk factors and their patterns and mechanisms. What do we know about the impact of structural stigma on sexual and gender minorities' health in Europe? Well, we have conducted several studies to try to understand that better. And those have been largely based on the varying degree to which legislations are discriminating and stigmatizing across these different countries. So to compare the situation between countries across Europe, we have used information about legalization and policies that the organization ILGA has collected from these different, they collect information about legislations globally, but also across Europe. And we have combined this information with information about population attitudes, mostly coming from the European Social Survey, which is a regularly conducted attitude survey in most European countries. To illustrate that, for example, in one question that had been asked multiple times in the European Social Survey is, do you think that gay men and lesbians should be free to live their life as they wish? And the proportion agreeing to this statement in different countries, we plot that on the y-axis, and put the x-axis, we have the discriminatory legislation. And as we can see, this is the average agreement to that gay men and lesbians should be free to live as their life as they wish by legislation, discriminatory or stigmatizing legislation. And as you can see, there's a clear pattern with higher stigma, lower degree of acceptance. So in some countries, most people, like Sweden, Norway, Netherlands, most people agree, but in Russia, only 15% approximately agree on to this statement. So huge differences, and they seem to be linked. Another question that was included recently in the European Social Survey was, if a close family member would be gay or lesbian, I would feel ashamed, with the average proportion reporting that now on the y-axis, and also plotted based on stigmatizing legislation. And a similar pattern too. Only like 5% reported that they would feel ashamed if a family member were gay or lesbian, but almost 70 in these countries here, like Norway and Germany, Netherlands, and 70 in Russia. So clearly there's very large pattern differences between where you live as a sexual minority. So we've used both of these information, both attitudes and in legislation, to try to study how people living in this country are reporting things. So we based these two studies on this framework, but had at least information about a few of the different constructs. We have structural stigma, the country and country index of stigma. We had information about victimization, discrimination, and also information about how open people were about their sexual or gender identity to other people in their lives. And also one item measure of life satisfaction on a scale from 0 to 10. So the aim of these two studies were really to see if life satisfaction varied consistently based on structural stigma, and if some of these things could explain it. Uh, To do this, we use data from a quite unique study, the European Union Lesbian, Gay, Bisexual, Transgender Survey conducted by the European Union Agency for Fundamental Rights. And they used web surveys to collect data from sexual minorities living in all European Union countries. So managed to recruit quite a few, like over 85,000 sexual minorities and almost 7,000 gender minority individuals, 18 years or older, with these questions. And the questions were things like sexual orientation, transgender experience, life satisfaction, as I said, a one-item question, experience of victimization and threats during past 12 months, day-to-day discrimination, and also a measure of concealment of sexual and orientation or gender identity. So we try to link these together. Just shortly, how we created an index based on both country legislation and attitudes using this question from the European Social Survey, and added them together, standardized them and added them together, and gave one index number for each country. For the transgender analysis, we used another attitude question. How comfortable would you feel about having a transgender or transsexual person as in the highest elected political position in their country on a scale from 1 to 10? So similar, not some kind of attitude question, and we combined attitude with legislation. So the results for sexual minorities then. So here, each country are coded based on country level structural stigma on the x-axis and the average country level life satisfaction on the y-axis. And we saw a very clear pattern, surprisingly clear pattern actually, that in the countries that have lower stigma, people reported higher life satisfaction and much lower in the Eastern European, much stigmatizing countries. And this explained a lot of the variance across countries. So clearly it matters where you live. Not too surprising, but still being confirmed by this data. We then wanted to try to explain it. And we first looked at concealment, that we thought was an important factor influencing this, and the same plot with average concealment score on the y-axis, so high concealment. And even clearer pattern here, that in lower stigma countries, fewer at least people were concealing their sexual orientation compared to in the higher stigma countries. So a very clear pattern. Almost 80% of sexual minorities in Romania and Lithuania reported concealing it to most people in their lives, whereas only 20% of course around in the UK, for example. So a very clear pattern. We then put this data into a multi-level mediation model and managed and tried to see if in fact structural stigma's influence on life satisfaction could be explained by this pattern through concealment, and we found that it did to a large degree actually explain. So most of the variance in life satisfaction across country could be explained by concealment by sexual minorities living in those countries. We also found one other effect of concealment, that if you live in a low stigma country, if you conceal or not didn't really influence how much victimization you were experiencing. However, if you lived in a high stigma country, like on this bar, it matters if you concealed or were open with your sexual orientation. Those concealing their sexual orientation were actually protected against victimization. And this is maybe also not so surprising, but it actually works in two ways. So to one degree, being concealed about your identity is negative for your mental health, but it protects you against victimization. Over to the transgender participants. We saw a similar pattern when it came to stigmatizing legislation, which we have on the x-axis, and the average level of life satisfaction on the y-axis. Not as clear as with sexual orientation, so clearly other things are also influencing transgender people's life satisfaction than their legislation, but it's still a pattern that was significantly predicting. We similarly made this multi-level mediation, and here we found two effects. So country-level structural stigma, influence of life satisfaction could partially, higher stigma led to higher concealment, which led to lower life satisfaction. So this explained quite a lot of the life satisfaction among transgender individuals. But there was also a significant other effect. Stigma led to concealment that the reduced likelihood of discrimination, which was related to life satisfaction too. So similarly, two kind of mechanisms operating at the same time for transgender participants. But we understand a little bit better of why we see this clear pattern across countries. So the conclusion is that sexual and gender minorities' life satisfaction vary greatly across countries, across different countries in Europe, and this variation can largely be explained by structural stigma of those countries and associated demands to conceal one's identity to avoid discrimination and victimization. And the finding really highlights the importance of trying to reduce structural stigma more generally to promote equal life satisfaction. And now today we see that the development goes in a positive direction in many countries across Europe, but also in a negative direction in some countries. Tailoring affirmative psychotherapies to address structural contexts surrounding sexual and gender minorities might be another way, of course, to increase coping and management with a stigmatized environment. So are all intersecting subgroups within the sexual and gender minority group equally impacted by where they live? That was another question we were interested in exploring. So we did that. We actually used the same data set, but looked at victimization specifically. And we wanted to see the role of gender nonconformity, and socioeconomic status. Here the aim was to investigate if sexual minorities living in higher structural stigma countries report more victimization than those living in lower structural stigma countries, and if this association between structural stigma and risk was strongest for those who reported being gender non-conform or had lower socioeconomic status. That was our hypothesis. And we also wanted to see if this varied by gender. So the material is the same. It's a survey done by the European Union Agency for Fundamental Rights, the EU LGBT survey, 86,000 almost sexual minority individuals. And here we used victimization and threats during the past 12 months. A measure of gender nonconformity was two questions. Do you agree with the following statements? I feel feminine, agree or not agree, and I feel masculine. And that made it possible for us to categorize people into gender nonconform or conform. We also had a few questions about level of education and income used for a socioeconomic status categorization. And we categorized each country received an index for their discriminatory legislation and attitudes towards sexual minorities. So just overall, in all groups, this is the pattern. So with increasing country-level structural stigma on the x-axis, more people reported being victimized during the past 12 months. With a quite clear pattern, 14% in Latvia, Lithuania, and about 6% in the Netherlands. So huge difference of exposure to recent victimization. We then, we both analyzed, but I will illustrate this by stratifying the different illustrations. So we looked here at men on the upper bar here and women on the lower. And gender conform people are in the blue and gender non-conform on the orange. And as you can see, for women, there was not it was a similar pattern for both those, gender conform and gender non-conform, with a slightly elevated across structural stigma countries. However, for men, it was quite different. If you were gender non-conform and living in a high stigma country, you had a very highest risk of being exposed to victimization. If you were gender conform, it didn't matter as much where in Europe you were living. So a clear effect moderation here by gender nonconformity, but also at least when we divided it by gender. This is the high socioeconomic status in the orange and the low and middle socioeconomic status in blue. And here you could see that all the blue dots, both for men and women, are higher. So low, middle, SES, it has like a main effect for socioeconomic status. You're more exposed to victimization if you have lower socioeconomic status. But it also matters where across Europe you live. With a higher, so those most exposed to victimization are really those living in higher structural stigma countries with low and middle socioeconomic status. So quite clear pattern here, and the conclusion is really that a much larger proportion of sexual minorities living in higher stigma countries report victimization than those living in lower stigma countries. That was the kind of the main effect. But at the same time, all sexual minorities are not equally impacted by their structural environment. If you're more conform and higher SES, you are less impacted. But the association between country-level structural stigma and victimization is most heavily concentrated among gender non-conforming men with lower socioeconomic status. So it's important to bring in these intersecting identities when you're trying to understand these mechanisms. So what do we know about the biopsychosocial mechanisms linking exposure to stigma to risk of poor mental health? So I will give two examples of studies we have done to try to understand this better. So we based these studies on this conceptual model, which suggests a few cognitive, emotional, behavioral, and biological mechanisms. I will specifically focus on one emotional mechanism and a biological mechanism. In the first study, we wanted to look at shame as an emotional mechanism underlying sexual orientation differences in mental health. And we assumed sexual minorities had high risk of mental health, and we had this model with social stress exposure, both general stress factors and sexual minority-specific stress factors being elevated among sexual minorities, giving rise to different types of cognitive, behavioral, emotional, biological mechanisms that could explain poor mental health. So that was kind of the background. We used a quite unique data set that we've developed during the past couple of years, the PLUS cohort study. It's a cohort study in Sweden, around just over 2,000 participants recruited from a random sample of the population. We oversampled the sexual minority group, so half approximately were sexual minorities, being assessed with regular surveys at 5 time points. And also we used multiple components. We assessed self-report mental health and self-determinants with questionnaires, behavioral tasks that you see down here, and biological markers of stress assessed at 3 time points. They were self-collected. So a rich data set that really tried to solve a lot of the limitations with previous studies that have mostly relied on cross-sectional studies or studies longitudinal but without a comparison group, and also not necessarily being representative of the underlying population. But this study should have all of those factors. So a quite unique data set. So we use this model, and particularly in this study, we wanted to focus on shame as an emotional mechanism. So the aim was to explore if shame mediates sexual orientation disparities in depression, social anxiety, and suicidality, which we thought were important mental health outcomes for this mechanism. To compare the relative strengths of two approaches to measuring shame, because it's not that easy to measure, both explicit and implicit, and to examine the association between family rejection and childhood bullying as mediated through shame. We thought those were two important factors leading to shame within the sexual minority group. So what is shame? Well, it's a self-evaluative emotion that involves seeing the self as socially inferior, flawed, and inadequate, often arising from perceived moral transgressions. Shame is distinguished from other emotions in being primarily characterized by perception of negative, uncontrollable aspect of oneself. Shame can also be distinguished from other emotions in its behavioral outcomes, including a desire to hide, isolate from others, and erase the self. So how did we measure it? We used a self-report questionnaire from a subscale of the personal feelings questionnaire, and also a self-reference encoding task. It looked something like this. So it was computer-based, and people were exposed for words and asked to answer as quickly as possible how this word describes you. And the word for shame, we said the words we used for this calculation was response time for ashamed and proud, in a clever way to calculate some kind of score of shame, implicit shame. And does shame then, our main aim, does shame mediate the sexual orientation disparity in depression, suicide, and suicide thoughts? So to begin here, we saw significant sexual orientation differences in all of these three outcomes. Not so surprising because we've seen that in other studies. But we then entered it in a multiple mediation model. So trying to explain this pattern through these two measures. So we have the explicit measure, the questionnaire measure up here, and the implicit measure here. And you can see that both these measures of shame were significantly elevated among sexual minorities. And they were all also related to our outcomes. We have the indirect effect here, and as you can see, the indirect effects were larger for the explicit measure of shame, but it was also significant for the indirect effect. And together they explained quite a lot of the sexual orientation differences in all of our outcomes: depression, social anxiety, and suicide thought. In fact, social anxiety was no longer significant when we entered these shame measures into the model. So yes, we found support for shame being an important mediator. We did a within group, so only within the sexual minorities, and saw if sexual past year family rejection based on sexual orientation and childhood bullying was related to the outcomes and could be mediated through these shame measures. And similar to what we saw before, almost all of these exposures, family rejection and childhood bullying, were related to shame. The only non-significant was childhood bullying with this implicit measure. And they were all related to depression and suicidality. So at least partially, the exposures to family rejection and childhood bullying could be mediated by these shame measures. So it seemed to play a role for explaining sexual minorities' increased risk. So to conclude, compared to heterosexual, sexual minorities experienced higher explicit and implicit shame, which mediated sexual orientation disparities in depression, social anxiety, and suicidal thoughts. Among sexual minorities, there was an increased effect of shame in the association between interpersonal stigma and later experience of adverse mental health. Yeah, I should also say we had these assessment timed, so it works. We could study this over time since we had longitudinal data. Results suggest extending existing stigma theories to consider emotions like shame as characteristic reactions to stigma and guide the search for treatment targets focusing on reducing the mental health consequences of stigma. So lastly, in this study, we looked at another mechanism. We looked specifically at neuroinflammatory mechanism in explaining sexual orientation differences in depression. And this is particularly exciting because few studies have examined biological mechanisms and few have used what supposed to be representative longitudinal data sets. And why did we want to use that? So again, we use this model, and we here specifically wanted to look at activation of the immune system leading to elevated inflammation. Why did we want to look at inflammation? Well, one promising theory describing our current knowledge about linking between exposure to social stress and depression is the social safety theory, and I will try to explain that shortly, or in a short way. So social safety theory has been described by George Slavich at UCLA and his colleagues in a number of recent publications. Well, the theory assumes that humans are social species that are primarily, and the primary purpose of the human brain and immune system is to keep the body safe. And according to the theory, social inclusion and safety serves an evolutionary purpose in historic time, increasing our chances of survival and protection from physical harm. And because our need for social inclusion and the protection provided by our social network, social exclusion and rejection from peer groups activates the biological signals that prepare the body for exposure to increased risk for harm. And the immune system is one such system, it's believed. So it is believed that when people are exposed to threats to social safety and experience situations which with continuously increased risk of being rejected and excluded, the immune system is activated, leading to elevated inflammation. And while short-term activation of the immune system is beneficial, long-term activation is detrimental and can lead to increased risk for certain diseases like depression, chronic pain, and of course, inflammatory diseases. The theory also suggests that the experience of threats to social safety early in life can lead to a strengthening of the neural link between increased inflammation and depression, like a stronger neural connection between the brain and the immune system. And this is a process called neuroinflammatory sensitization. So the aim of this study was to examine if early experiences to threats of social safety in the form of adverse childhood interpersonal events is related to childhood depressive symptoms, so that connection, and the aim to if inflammation could mediate some of this association, to really test the first assumption of the social safety theory that adverse events lead to inflammation, lead to depression. Our third aim was to see if this experience of early adversity linked to inflammation is particularly common among sexual minorities because they are socially exposed to more social adversity. And if this pattern could, to some degree, explain sexual orientation differences in depression compared to heterosexuals. The fourth aim, we wanted to test a neurosensitization hypothesis, to test the link between inflammation and depression and see if that's stronger among sexual minorities because of their greater likelihood of experiencing threats to social safety. So those are the four aims. And we used data from this PLUS cohort, the 4 first years actually, and 2 assessments of blood samples. Not everyone was invited to collect blood and not everyone managed to return them, but we had at least almost 600 individuals. Almost half of the sample were sexual minorities, but that was because there was oversampled, and exactly, and most participants were born in Sweden and were women. So results then is early experience of threats to social safety in the form of adverse childhood interpersonal events related to adult depressive symptoms. Yes. We assessed depression with a latent variable with all 4 assessments of depression as indicators, and we found a significant association. Aim 2, can chronically elevated inflammation partially explain the association? Well, again, yes, we used also a latent variable for chronic elevated inflammation, and then we used the average of the 2 assessments of C-reactive protein, interleukin-6, and TNF-alpha, or tumor necrosis factor alpha, which are indicators, biomarkers of inflammation, and calculated something that gave a measure of chronically elevated inflammation. It was elevated among those exposed to childhood interpersonal events. and could explain some of the increased risk for depression. So the indirect effect was significant. The third aim then, are sexual minority individuals more likely to have experienced this childhood events linked to inflammation? And in fact, yes, the indirect path explained approximately 16% of this pattern. The sexual minorities were more exposed to adverse events, which led to depression, but also this longer path through inflammation was also significant and could significantly contribute to explain sexual orientation differences in depression, giving support for the social safety theory. So the last aim is the link between chronically elevated inflammation and depression symptom severity stronger among sexual minorities compared to heterosexuals. So here we entered sexual orientation as a moderator of this association. And it turned out to be significant, providing support for the difference in association between chronically elevated inflammation and depression symptoms among sexual minorities compared to heterosexuals. And if we analyzed stratified analysis, we saw this effect. So the link was stronger for sexual minorities, around 0.366 for sexual minorities, and 0.223 for heterosexual. It was still significant for heterosexual. Depression and inflammation was linked, but much more stronger among sexual minorities. So this gives support for the neurosensitivity sensitization hypothesis. Just to conclude, this is one of the first longitudinal population-based studies that demonstrate the role of chronically elevated inflammation in linking threats to social safety during childhood with depressive symptom severity in young adulthood, consistent with the primary tenets of the social safety theory. It also extends the theory by finding that chronically stigmatized population, in this case sexual minorities, experience a greater risk of depression because of its greater exposure to adverse childhood events linked to inflammation. And we also found that among sexual minorities, depression is more likely to be linked to inflammation. So in addition to efforts to reduce sexual minority stigma, case conceptualizations should address the source of sexual minority clients' depression, including early experiences. And future research should try to explore why sexual minority individuals' depression is more likely to co-occur with inflammation, and potentially how this can inform targeted treatments. So over to some final conclusions. Our studies to date, using data from across Europe and Sweden, support our conceptual model and show that stigma at multiple levels impact on sexual and gender minorities' health and well-being. This can be helpful in promoting legislation and policies that have an impact on sexual and gender minority individuals' health and life satisfaction, but it can also help inform targeted intervention through understanding the mechanisms better. But what we really need now to move forward is future longitudinal assessment of mechanism across diverse contexts that will generate increased understanding of the biopsychosocial mechanisms linking multi-level stigma to poor health, and how those mechanisms look different in different social environments. Thank you so much. That was all I had prepared to present for you today. I'm happy to take any question. Thank you.